Evening, everybody. Thank you for taking the time out of your evening so close to Christmas. I'm sure you're all very busy with your Christmas preparations. We are just admitting a few more people into the call before we make a start. And if people join late, that's absolutely fine. So this meeting will be recorded and it will be available to you after the event this evening. So if you need to access that after the event, that's absolutely fine. You'll be able to do that. My name is Ellen and I'm one of the tissue viability nurse advisors working with Coloplast. And I'm joined on the call this evening by my very good friend and colleague, Charlie Pick, who is another one of our tissue viability nurse advisors. So the way this will work is for the next hour, I am going to be talking to you about how we make life easier and simplify wound healing for leg ulcers. So I will be sharing my screen with you so that you can see the slides. Because I'm sharing my screen, I'm not going to be able to see any of the chat. I'm just going to be able to see the slides that I'm sharing. So what I would encourage you to do is to just pop any comments or questions into the chat function. Charlie will be able to answer your questions and reply to your comments within the chat function, and then I will come back to Charlie at the end just to see what you've all been talking about, which will be really interesting. So really excited to be able to present to you this evening, and without further ado, I'll share my screen and we'll get the presentation going. Okay, I'm sure Charlie will tell me if people can't see my slides, but I'm thinking everything's okay, Charlie, is that right?
Yep, we can see your slides, Ellen, thank you.
Fab. Okay, so like I said, this evening we're going to be talking about how we make life easier through a simplified approach to wound healing, specifically geared towards leg ulcers. So that's what we're going to be talking about tonight. So hopefully you'll find it very interesting and give you a few ideas, make it a bit thought-provoking for you about what your current approach is and how possibly you could have a different approach. How could we manage these patients a little bit differently moving forward and change our practice? So as I've said, we're going to look at a simplified approach to wound healing, and we're going to do that through what at Coloplast we've now adopted as being the 3-step approach, which is a really simple step-by-step framework to help you as clinicians effectively assess patients with wounds. Today specifically we're talking about leg ulcers, how we prepare those leg ulcers, and how it's really important that we now pay careful attention into our preparation of these wounds that can often be on patients, or patients will be living with them for prolonged periods of time, and they're on our caseloads for a long period of time as well, so taking up a lot of capacity, taking up a lot of resource from our services. And there's a different way that we can approach this, which can, as evidence shows, have different outcomes for our patients and for us as clinicians. So we're looking at that simplified approach. We need to understand a little bit of what the impact is. What is the burden currently within the UK of patients who are suffering with leg ulceration? We need to have a little look at what the latest leg ulcer recommendations are in terms of best practice, and we'll be looking at what the National Wound Care Strategy Programme are talking about at the moment, and their latest recommendations in terms of the leg bundle, which was released earlier this year. And then we're going to also have a little look at a leg ulcer pathway, a simplified leg ulcer pathway, which will help support your practice in that simplification of approach moving forward. We want to look at the impact. So, you know, what is the problem? What is the problem in the UK at the moment in relation to leg ulcers? Well, we know that it's very well recognised that leg ulcers are as a result of an underlying venous disease, and they're actually the most common etiology of leg ulceration. It's the most common reason why a patient with a wound on the lower limb has a difficulty with getting that wound to heal. It's because of their underlying venous disease. There was a study done in 2015 which found that there are at least 730,000 patients with leg ulcers in the UK. That's a phenomenal amount of patients, and around 1.5% of the adult population were actually living in 2015 with a leg ulcer. So how long ago was that? 2015, we're talking 8 years ago now. So do we think that number has gone up or gone down? I would argue that that number is probably a lot more now than it was back in 2013, where Julian Guest did his study to look at the burden. More evidence to suggest that this is now estimated to have increased by 101%. So evidence to suggest that actually we are now dealing with a much larger problem than we were in 2015. And again, this is from research that was done by Julian Guest. So the number of diagnosed venous leg ulcers indicates that 1 in 170 adults have a venous leg ulcer, but we also know that there is a huge amount of patients who have a wound on the lower limb which is undiagnosed. So I would suggest to you that if the patient has a wound on the lower limb which doesn't have the correct diagnosis, that would indicate that that patient probably isn't along the right pathway of care. They're probably not having what is recommended as best practice management for the etiology of the wound that they have. If we don't know what it is that we're dealing with, how do we know how to then manage that patient and put that patient on a trajectory towards healing? And leg ulcers have a huge financial burden to us within the NHS in the UK as well. They often require long-term care, so leg ulcers can be present for a protracted periods of time, particularly if that diagnosis isn't made and early intervention implemented. With variation in practice, which can increase costs in care, and obviously that can impact on the extended healing times for patients. So 1.94 billion pounds, that we spend on leg ulcer management and leg ulcer healing. We've already looked at, how many patients are suffering with a leg ulcer currently. But an average of £7,600 per patient with a venous leg ulcer, it's a huge amount of money. And how much can we impact on that cost if we adopt early intervention and look at what the National Wound Care Strategy Programme are recommending as to how we manage these patients with wounds on the lower limb? And then when we look at those patients who have unhealed venous leg ulcers after a protracted periods of time living with that ulcer, that cost is obviously going to increase because of the amount of time it takes us on our caseloads to manage these patients, the amount of products that we need to use, the amount of antibiotics, the amount of drugs, the amount of inpatient stays, the amount of referrals, clinic appointments. All of this can increase the cost that we spend on looking after these patients with these really often complex wounds. I've talked a little bit about a simplified approach. So at Coloplast, we talk about a 3-step approach, with step 1 being the assessment of a patient. And this isn't just, solely looking at leg ulcers. We adopt a 3-step approach to all wound etiologies, but tonight we're looking at leg ulcers specifically. So we know that we need to do an assessment, a robust assessment, a holistic assessment of our patient is fundamental in defining what our treatment objectives need to be for that particular patient. And we use something called the triangle of wound assessment in Coloplast, which looks at our overarching holistic assessment of that patient, where we look at comorbidities, medications, allergies, lifestyle, all of those different factors that we know can affect that patient's healing trajectory. And then we look in a little bit more depth at the wound bed, the wound edge, and the peri-wound skin to understand what it is that we need to do for that particular patient. It's a really simple wound assessment framework that can really help us to identify what our healing objectives need to be. And then step 2, we look at wound preparation. We know now that there is much more emerging evidence around wound preparation and how much wound preparation should be a fundamental part of that patient's care plan. What is it that we've identified that we want to achieve? How do we achieve that? And what part does wound preparation play in making sure that we get the best out of our treatments that we then decide upon for that patient? So wound preparation is absolutely key to removing those barriers to healing, making sure that we get that optimized wound healing environment. We disrupt those biofilms, we remove any barriers to healing, such as foreign bodies, debris, devitalized tissue. We disrupt those biofilms, and then we're going to also get the best out of our treatment that we decide upon for that particular patient. And there are also simplified methods of treatment that you can use as part of that patient's whole care plan. So let's look a little bit in depth about wound assessment. Why do we do a wound assessment? Well, we need to understand why that wound is there in the first place. If we don't understand why the wound is there, then we're unlikely to select the correct wound management plan for that particular patient. We might be, a bit nervous or cautious about the wound preparation that we do, and we might not choose the appropriate treatment regime for that patient when we've, understood what our healing objectives need to be. So we need to understand why that wound is there. We need to understand if there are any associated risk factors for that particular patient. So is the patient at increased risk of infection, for example? Is the patient particularly malnourished, which might be something that we need to optimize? So we need to understand what could potentially be a problem for the patient that is presented to us that has a wound on the lower limb. We need to correct or treat any underlying cause. And with leg ulcers specifically, if we don't manage the underlying problem, then potentially we could have an adverse outcome or not optimal outcome for that particular patient. When we're looking at leg ulcers particularly, the treatment regime for an arterial wound would be very different to the treatment regime for a patient with an underlying venous problem. So if we don't manage those underlying conditions, then we're not going to have the best outcome for that particular patient. And that leads into what are the appropriate management options for our patient. So in lower limb wounds, we know that if the patient has underlying venous disease, then the most appropriate management is to manage that venous return, to optimize that venous return for that particular patient, to get the blood getting back up the leg as it needs to be to promote that healing for that particular patient. Whereas if that patient has an arterial problem on their lower limb, then putting compression to optimize that venous return when the patient is already arterially compromised is potentially going to have an adverse outcome for that patient. So we need to know what's appropriate as part of our assessment as well. Wound-related symptoms. So what we might perceive as a symptom for that patient might not actually in reality be an actual problem for that particular patient. But I would suggest that the most common problems in relation to leg ulcers would be leakage of the dressing, of the wounds onto their clothing, onto their bedding. Odour can be a particular problem in relation to the patient. And I think sometimes as clinicians, we can become a bit complacent about malodour in terms of wounds because, that wound is only under our nose for that period of time while we're doing that patient's dressing. But let's bear in mind that that wound is under that patient's nose 24 hours a day, 7 days a week, and can pose very significant problems for that patient in terms of embarrassment, in terms of them becoming socially isolated, cause low moods and depression. It can affect appetite, which then can affect nutrition intake. So we need to bear all of these symptoms in mind for our particular patient. We don't want anything we do to make things any worse. So the dressings that we use, the wound preparation that we use, we need to make sure that they're appropriate for the objectives that we identified as part of our assessment. So exudate management, I would imagine, is a really significant thing that we could potentially be at risk of getting wrong. If we don't identify the amount of exudate, if we don't identify the colour of that exudate and the viscosity of that exudate, then the dressing that we use to manage that exudate might not be appropriate for that particular patient and could potentially cause that wound to deteriorate. Understanding what the patient's expectations is really key as well. So in terms of leg ulcers, you might have a patient who has had a leg ulcer on their leg for quite a long period of time, and they would absolutely love that wound to heal. But they live in the real world, and their expectations are realistic. So what might be our aim, which is for the wound to heal, might not always be the patient's initial aim. So the patient might love their wound to heal, as quickly as possible. However, they might be struggling with issues around exudate and the bandages that they're asked to wear, for example, which might impact on their day-to-day activities of living. So understanding what the patient wants to achieve is really, really key. and involving them in the decision about the treatments once you've identified treatment objectives is also really, really key, specifically in leg ulcer management, because when we talk about compression, there needs to be patient involvement in the choice in the products that are used to manage their wound, and who it is that is managing their wound. Is there going to be some kind of shared management or self-management? So we need to be involving those patients as well, promoting that independence and providing that motivation, using motivational interviewing techniques to understand what it is that is actually the problem for that patient, and how can we contribute to making sure that we both get to where we need to be for the patient. I mean, let's face it, wound assessment can be really, really complex. And there are lots of different reasons why wound assessment can be complex, whether that be issues that are specific to the wound itself, such as the dimensions, the exudate level, signs of infection, for example. It might be issues which are specific to the patient, so their comorbidities. Patient might be diabetic. Patient might have different lifestyle choices which are not conducive to effective wound healing. There might be organisational factors, which might be, inappropriate skill mix within different district nursing caseloads, for example, or within primary care. Is there enough people there who have the skills to manage these patients with leg ulcers? There might be educational factors, so when, did you last receive any education and training around how to assess and manage a patient with a leg ulcer? What is the access to different organisations to appropriate education? So all of these things can add to the complexity of doing an assessment and managing these patients appropriately. We are given national guidance about how often we should do a wound assessment on a patient, but obviously it will always be guided on what the condition of the patient is, in itself. So how is the patient generally? And if there is any change in that patient's condition, then that might prompt you to do another wound assessment or re-evaluation of that patient's wound. But at a minimum, a holistic wound assessment should be undertaken every 2 weeks within an acute setting, or every 4 weeks within a primary care or community setting, but always revert back to what your local policies, guidelines and pathways are for your patients. I've talked a little bit about the triangle of wound assessment, but essentially it's a simplified assessment framework which looks at the patient's comorbidities, their lifestyle choices, what their mobility is like. So looking for all of the different potential red flags which might prevent this wound from healing in a timely manner. And then once we've taken all of those things into account, we look a bit more closely at the wound itself. So we look at the wound bed, we look at the edge of the wound, and we look at the peri-wound skin or the surrounding skin. And we come up with treatment objectives for those patients. What did we identify on the wound bed? What do we need to do about it? Were there any challenges at the wound edge or on the surrounding skin? And therefore, what do we need to do about it? So looking at legs and leg ulcer underlying etiologies in a bit more depth. So any indicators of underlying venous disease would include any patients that have a past medical history of deep vein thrombosis, any pulmonary thrombosis, any previous fractures in the lower limb. If there's any history of venous disease or any evidence that there's any history of varicose veins for that patient or within the family. Clinically, what you see on the leg is also very significant. So it's really important to understand what it is you're actually seeing when you do a clinical examination of the patient's lower leg. So in the image here, for example, you can see that this patient has signs of ankle flare. So you can see those thread veins, which are really prominent on that patient's ankle. You can also see signs of pigmentation or staining or hemosiderin deposits, you might see it as. So this is where, because those small vessels within the lower limb are under high pressure and stretched, red blood cells will leak out of those capillaries and cause staining. So they will leave iron deposits in the surrounding skin. And this leakage of these things outside of the small vessels can also cause things like eczema or irritation in the surrounding skin. So all of these things within this list you need to be familiar with and looking out for when you're doing a clinical assessment of your patient. So other medical conditions which would be risk factors for venous disease would be things like hypertension, chronic swelling of the patient's lower limb, sometimes any hormonal irregularities or arteriovenous fistulas. Their lifestyle we need to look at as well. So is the patient particularly overweight, where there is going to be increased pressure put on the lower limb vessels, which can again cause high pressure and it really cause a compromise to that venous return for the patient. Stress, history of intravenous drug use, their occupation, if they had an occupation such as like a hairdresser, a nurse or a chef where they've spent a long time, stood on their feet. All of these things can put pressure, putting the patient at risk of venous disease. So then when we look at underlying indicators of arterial disease, again, we look at the patient's past medical history. So does that patient have any history of cardiovascular issues, such as, previous MI, previous strokes? We look at heart failure, all of these things which are heart related, which could potentially reduce the arterial supply to the patient's lower limb. What you see on the leg or other things that the patient discusses with you might be intermittent claudication. So when the patient walks for a certain distance, they get cramp in their calf. So that's an indication that the blood is not getting down to their lower limbs and causing that sort of cramp type pain. So all of these things are red flags in this list that you would look out for when you're doing an assessment on a patient who has a wound on the lower limb. Other risk factors in terms of the medical conditions might be, again, hypertension, diabetes, any rheumatoid arthritis, which can cause problems in the small vessels in the feet, increased lipidemia, so hypercholesterolemia, again, any hormonal irregularities. Again, we look at their lifestyle. Do they smoke? What is the cholesterol like? Are they overweight, which means that they might have had, a diet which could have contributed to their cardiovascular disease. All of these things we need to take into account. So we look at the wound bed itself as well. We look at any tissue types, and these are the most common tissue types that you would see on a wound bed. We need to make an assessment of what kind of tissue that we're seeing, and we need to document that accordingly using a percentage method. So is it 80% sloughy and 20% granulating? We need to document all of this on our wound assessment charts or wound care charts. We look for signs of infection, so whether that be increased pain, redness, swelling, localized warmth. Is there been any increase in exudate levels, or just general delayed healing that you can't put down to anything else? Malodor, we've already discussed, is obviously a sign that there might be an infection for that particular patient. What is the exudate like? Not just how much there is, but what is the consistency? What is the colour of that exudate? And do we need to be concerned about, in terms of infection, any or spreading or systemic infection that we might need to take further action on to prevent the patient deteriorating to sepsis, for example? We then look at the wound edge, as I alluded to before. So these are the common challenges that you might see at the edge of the wound. So maceration is a really common challenge at the wound edge, and that's essentially all about exudate management. If we're not managing that patient's exudate effectively, then we are potentially going to have problems at the edge of the wound. And let's not forget, when we think about the wound healing process, and we look about how, where does the epithelial migration come from? And epithelial migration comes from the edge of the wound. So if you don't have a healthy wound edge, whether it's too dry or too wet, you're not going to get those epithelial cells resurfacing that wound to ultimately cause that wound to heal. So we need to be making sure that we are managing the moisture, the amount of exudate effectively, across the wound bed, across the wound edge, and across the surrounding skin. Peri-wound skin, again, we see maceration on here, and this is a wound that you can see in this clinical image that is heavily macerated at the edge of the wound, but it's not being prevented, it's not being dealt with effectively, so that maceration has now progressed onto the surrounding skin. And this patient here on their heel is at huge risk of that wound enlarging and that heel becoming involved within that wound, if you like, because that skin integrity has been really compromised by the amount of exudate that has been sat on it. Again, it's about exudate control. Excoriation is another common problem. So again, if you've got exudate that is sitting on healthy skin, it's going to cause irritation, it's going to cause a problem, it's going to cause itching, causing the patient to scratch, as does dry skin. We don't want dry skin, we don't want excoriation on our peri-wound skin. We want to calm down or remove any hyperkeratosis. So we want to remove the opportunity for bacteria or microbes to proliferate on our surrounding skin. So all of these things are really common challenges that we need to deal with as part of our assessment and come up with treatment objectives. Sometimes we need to do further investigations to help us diagnose what it is that we're dealing with. So we've asked all of our questions. We've identified any, red flags to healing. We've looked in terms of the lower limb assessment more in depth at any venous signs, any arterial signs. But then we might need to do something a bit more. We think we know what we're dealing with, but we might need to do a bit more investigation just to confirm what we actually think is going on. So any patient with a non-healing wound, whether that be on a lower limb or anywhere on the body, it's always really helpful to do a full blood screen because you can identify things that possibly the patient doesn't already know about, and you don't already know about, such as anemia, such as hyperglycemia, so increased blood sugars. So, there are lots of diabetics that are undiagnosed walking around out there. So if a patient's got a wound that isn't healing, often a full blood screen can help you to identify any potential problems which could be contributing to that non-healing. If you have a non-healing wound where the patient you've decided to implement a topical antimicrobial, for example, but the wound still isn't progressing or has deteriorated despite what you've implemented, then you might need to identify what pathogens are causing that patient's infection, and that will help you to identify what antibiotics might be suitable in that particular situation. We're talking about leg ulcers here, aren't we? So we need to ultimately do an ABPI. We need to understand what the arterial perfusion is to that lower limb, and that helps us determine whether it's safe to apply the amount of compression that we want to improve that venous return, to get that circulation doing what we want it to do, to get that wound healed as quickly as possible. And then with any patients who are diabetic, we know that peripheral neuropathy is a common symptom or side effect of diabetes. So you might have the skills to do pressure perception using monofilament to assess the extent of that patient's neuropathy. I've mentioned a little bit about the National Wound Care Strategy Programme, and there are recommendations available now, released in August of this year, for immediate and necessary care. And these are some of the red flags that you need to be aware of before you implement that immediate and necessary care. So we need to look for these red flags when we're doing an assessment of a patient. So if we're identifying that the patient has an acute infection, any symptoms of sepsis, any suspected either acute or chronic limb-threatening ischemia, so reduced blood supply, any suspected acute DVT for the patient, if you're suspecting that there might be a malignancy there, or if there's bleeding varicose veins, then you would need to escalate these red flags and refer to appropriate clinical specialists. But again, always refer back to what your local guidelines and pathways are for these patients. So what is immediate and necessary care? Well, we need to make sure that we arrange for a comprehensive holistic assessment, including ABPI, within 14 days of the patient presenting with the wound on their lower limb. We need to treat any wound infection that we might have identified as part of our assessment. We need to do really good wound preparation and cleanse the wound bed, the wound edge, and the peri-wound skin, and apply any appropriate emollient that we need for that particular patient. We need to take a digital image, so get our baseline, so that we can do, as part of our reassessment, we can identify if that wound is improving or static or deteriorating. We need to make sure that the dressings we used have sufficient absorbency, are not going to cause any further trauma for the patient. And for those patients who don't present with any red flags, we need to offer mild and graduated compression for that particular patient in the interim until we can get that full lower limb assessment with ABPI completed for that particular patient. And we obviously need to signpost that patient to any relevant high quality patient information. And there is patient information within the National Wound Care Strategy Programme website. So I would encourage you to explore that website to see if there's anything that you can use, or even look within your local information. There might be patient information leaflets available to you locally within your organisation that you could access to give that information to patients. So within 14 days, we need to make sure that we, for patients with any suspected venous disease where they have an adequate arterial supply, we need to make sure that that patient, so we've done our ABPI, we're satisfied that that patient has adequate arterial supply, we need to refer them into vascular services for more potential diagnosis and intervention if that is deemed required for that patient, and we need to get them into strong compression therapy. For any patients who have suspected mixed etiology ulceration on the lower limb, if that patient has an ABPI of less than 0.5, we need to make sure that we refer that patient into vascular services urgently. And patients with an ABPI that is greater than 0.5, well, between 0.5 and 0.8, we need to also refer those into vascular services for more investigation as well. And if we're just not sure, we need to make sure that we refer that patient onto somebody or a service who is able to do that more in-depth investigation to understand what it is that you are dealing with. For patients that have an ABPI of greater than 0.8, consider the use of strong compression for those patients. And for patients with lymphedema, we know that this can be an extremely complex etiology and very specific skills needed in the management of lymphedema often. So make sure that patients who do have signs of lymphedema are managed by clinicians who have the capability to be able to carry out that care. So what is an ABPI? Well, essentially it's an ankle brachial pressure index, and it gives us an indication of what the arterial perfusion is to that lower limb. And it is split into different sections. So when you measure the ratio of the systolic blood pressure at the ankle and arm and do a comparison, you will come up with a ratio. So when that ratio is less than 0.5, that's essentially only around 50% of the blood supply is getting down to the patient's foot. So we need to consider that we don't really want to be applying compression in this situation because we're just going to make the situation worse. So compression therapy would definitely be contraindicated in this particular circumstance, and we want to get that patient seen by a vascular surgeon as urgently as possible. If it's between 0.8 and 1.3, that ratio, that suggests that there isn't really any significant arterial disease, and compression can be applied safely for most people who fit within that bracket. If it's greater than 1.3, then potentially that might be suggestive of arterial calcification. So we can use compression therapy, but with caution, and again, refer that patient into vascular services. If it's greater than 0.5 but less than 0.8, then again, are we looking at mixed etiology? We need to avoid compression, but reduce compression potentially with caution and under specialist advice, and again, referring to vascular. When we've done our assessment, we need to make sure that we confirm everything that we've done with the patient. You know, what is it that you're going to do to me as the patient? Do I need to be referred for any special investigations? Where will that be? Who is it that is going to do that investigation? When will that be? Is anybody else going to be involved? Are you referring me to dermatology? Are you referring me to vascular? Are you referring me to tissue viability? You know, all of these places that potentially you might have decided that the patient needs to be seen by different members of the MDT. So the patient needs to be fully informed of all of that. Any specific treatment details you might need to run by that patient and go in depth sometimes, particularly with compression therapy. Because with compression therapy to manage venous disease, the patient absolutely needs to be brought in to that treatment regime, because that's how you're going to get the best out of concordance with the patient, to make sure that they're motivated and empowered and have been part of that decision making. Have a think about supported shared care or self-care for the patient. We really need to be empowering patients with wounds these days to be taking more of a part in their management regime, to be, you know, using these simplified treatments themselves if it's appropriate for them. You need to, check that they understand what it is that you've discussed with them, understand what the plan is for them, and ask any question, address any questions or concerns that they may have in what you've discussed and decided. So we've looked at assessment as part of the three-step approach. We now need to look a bit more in depth at how we prepare wounds and how that is really key and fundamental to remove those barriers to healing to get the best outcomes for our patients. And I'm sure the images that you can see on the screen here, are common to you. So patients that have wounds with excess fibrin and slough, any patients that have the wound bed, obscured by necrotic tissue, where you can't really do a really good assessment because you can't see what's going on underneath that devitalized tissue, and patients who might have, dry skin or hyperkeratosis on their peri-wound skin or surrounding skin. These are really common challenges that we need to address as part of our wound preparation regime. We know that around 80% of wounds, up to 100%, some studies would say, have issues with biofilm, which are delaying that wound healing. So what is a biofilm? Well, a biofilm essentially is a community of microbes with genetic diversity. So they live in groups. They live in groups within in chronic wounds, within the wound bed, in all of the little nooks and crannies that you see in the likes of leg ulcers and pressure ulcers and different wounds that are slow to heal. So the microbes live in groups, and they are protected in a chronic wound or a hard to heal wound because there is often devitalized tissue there, which give them that protection. And it's often not just one pathogen that is causing or living in its group of protection. Often there can be different pathogens causing that biofilm problem. They have a significant tolerance to antibiotics because of the protection that they have. And the host or the patient's immunity just isn't able to deal or fight the chronic state of inflammation that the biofilms are causing. So biofilms are not visible to the naked eye. They are too small to see. But if you see any signs of infection, delayed wound healing, any increasing levels of exudate and slough, that increased inflammatory response, all of the things that you can see on this list here, you need to think, is this a biofilm that's causing a problem that we need to do something about? And this is where wound preparation is absolutely key. And the International Wound Infection Institute give us best practice guidelines for how we manage biofilms and wound infection. And it needs to be a three-pronged approach. So the first prong of the attack on biofilms and infection is wound preparation. We need to disrupt that protection that those biofilms have. We need to get rid of that devitalized tissue where they are hiding, where they are given that protection from any attack, whether that be from antibiotic or whether that be from topical antimicrobial. If we don't do that disruption, the treatments that we then decide upon are not going to be as effective. So we really need to have a robust method to cleanse and debride the protection that those biofilms have within the wound bed, the wound edge, and on the peri-wound skin. We then, in prong 2, need to make sure that we use a dressing that prevents maceration. So we need to deal with exudate really, really effectively. Any time in a wound bed, and even if this wound appears superficial, so you wouldn't potentially be able to measure any depth to that wound, there will still be nooks and crannies within that wound bed where exudate has the opportunity to pool. And if exudate has the opportunity to pool, bacteria or microbes have the opportunity to proliferate. So we need to reduce the risk of that happening. And we need to make sure that the dressing that we use deals with that exudate in the most effective way to remove it from the wound bed. We need that dressing to get into all of those little nooks and crannies. We need it to conform to that wound bed to make sure that that exudate is dealt with at the point where it becomes a problem or before it becomes a problem. And then once we're using a dressing, so we've disrupted the biofilms, we've applied a dressing that's going to deal with the exudate effectively, we need to make sure that we use a dressing that is going to suppress that biofilm formation and deal with any residual biofilms that are in that wound bed. So we need to have a dressing that has an active ingredient which will donate that active ingredient into the wound bed itself. Because biofilms and bacteria, they don't just sit on the surface of the wound bed, they sit within the deeper tissues. So you need to have a dressing that donates its ingredient, its active ingredient, into those deeper tissues to kill those microbes. And it needs to do it in a sustained way over a sustained period of time so that you and your patients can be rest assured that the dressing, as long as that dressing is in place, is going to be actively fighting those biofilms, those microbes, that bacteria, to prevent any reoccurrence of that problem. So cleansing and debridement is absolutely fundamental. We call it step 2, and often I would suggest in previous years it might be a step in our wounds management plan, our wound healing plan for our patients, that we have either played lip service to or we've skipped altogether. But we now know that we get the best outcomes by doing really good wound preparation for our patients to remove those barriers to healing, like slough, non-viable tissue, and biofilms. And we have evidence to suggest that, the frequency of wound preparation is really, really key and can have really, really dramatic results in speeding up the healing time for patients. So this infographic that you can see in front of you on this slide is from something called the Wilcox study, which was a retrospective study that looked at over 312,000 wounds of all different etiologies. But in the middle of the slide, you can see that we focus specifically here on the average healing time for diabetic foot ulcers. And the comparison that we can see is between diabetic foot ulcers that were either debrided once every fortnight or once a week. And you can see the dramatic difference in the average healing time for wounds that were debrided, across those two different frequencies. So those wounds that were debrided once a fortnight took on average 76 days to heal, whereas those wounds that were debrided once a week, the healing time is reduced to 21 days, and that's massive, and we can't not pay attention to that. And this was around, within that 312,000 wounds, this was around 56,000 diabetic foot ulcers that were part of that study, and that's something that we really do need to pay attention to. There are best practice recommendations again in relation to wound preparation, and these were published in 2022, so not that long ago. And it helps us look at what is it that we're talking about? What do we mean by wound preparation? What is the terminology that we use? And what level of competency or knowledge and skill do we need to do really good wound preparation? So at the top end of this flowchart, you can see here we talk about washing and cleansing wounds. And you can read from the slide. I don't need to read it all out, but we know that when we wash or cleanse wounds, we don't necessarily need any extended competency or training to be able to do this task for our patients. As we move further down the list, so we're looking at the lighter blue bit of the flowchart, we talk about the different methods of wound preparation. So whether that be autolytic, mechanical, biological, and enzymatic wound preparation, we know that we don't need any extended competency or training to be able to do these methods of debridement, but we need to know what it is that we're doing with the product that we've decided to use. So the dressings that we use, the tools that we use in terms of mechanical debridement, biological debridement, we need to know what it is that we're trying to achieve and how the product that we've selected or the method of wound pressure preparation that we've selected actually works. Is it simple to use? Is it the best option available to us? Is it the best option available to the patients that we are making decisions about? And then we move to the bottom, we look at sharp or surgical debridement, which is, as the name suggests, this is something that is carried out using a blade. So that might be a scalpel, it might be a curette, it might be scissors, where we physically remove any devitalized tissue. And obviously, given the level of risk associated or potential risk associated with this method of wound preparation, you can imagine that extended skill and competency and training and capability would be needed to be able to do this. So think about how the tools that you have available to you and which method is simple to use and which method is most appropriate for your patient. So the National Wound Care Strategy Programme recommends that wounds and surrounding skin are cleansed and debridement needs to be considered if required. And given what we discussed earlier, that around 80% of wounds that are difficult to heal have a problem with the biofilm. So what is the simplest way to try and combat this problem? How often do we do it? Well, we've looked at the Wilcox study and we can see the difference made just increasing the frequency from once a fortnight to once a week. But what we're trying to do is we're trying to accelerate that healing to make sure that the treatments that we then decide upon are most effective, or we get the best out of them. But it's going to be an approach that we really should be thinking about undertaking at each wound care intervention that we do for our patients, or even sometimes that the patients can do themselves if they're taking part in their wound care, based on your assessment, based on your clinical judgment, what it is that you're trying to achieve. And obviously we need to take pain into account when we decide on the most appropriate method for our patient. There are situations where we do need to exercise caution. So we've talked a lot, because we're talking about leg ulcers today, about lower limb perfusion. So what is the blood supply to that particular wound? So if we are concerned about the amount of blood that is getting down the patient's leg, then we might need to exercise caution in the method of debridement that we use, or whether we do wound preparation at all for our patients. It's not to say that we shouldn't do wound preparation in this situation, but we might need to exercise caution and get specialist advice if we have any concerns. So we've looked at step 1, we've looked at step 2, we now need to think about step 3. So we need a simplified portfolio of dressings to manage wounds that we come across in terms of leg ulcers. So your wound assessment and your preparation helps you to identify objectives for healing, and then you have a portfolio of products available to you, depending on what your objectives are. So is it that you want to manage exudate? Is it that you have a wound of significant depth that you need to manage that gap to prevent that exudate from pooling? Have you seen any signs and symptoms of infection that you want to address as part of that patient's management plan? And you will have, as I've said, a portfolio of different dressing categories available to you. And I'm not going to go through the list. You will all, I would imagine, have wound care formularies that you adhere to. And these should all have descriptors of what these actual categories of dressings actually do. And you know, not one method is right for every patient. Every patient's wound is different. Every patient is different. What works for one won't work for another. And we often need to use a variety of techniques to achieve the goal that we want to achieve. So again, reverting back to National Wound Care Strategy, they recommend the application of a simple to use dressing that is low adherent with sufficient absorbency. So what dressings do you have available to you that meet this criteria? So for those patients that we suspect it's a venous etiology and they have an adequate blood supply to their lower limb, we need to implement strong compression after we've done our full lower limb assessment. So hosiery kits for ulcers that are active can be really, really useful, and can be a simple method of how we give that strong compression for patients. And there are different, the hosiery kits are available, but essentially what we want to do is deliver 40 millimeters of mercury pressure at the ankle, reducing to half that amount, so 20 millimeters at the calf. So consider if your patient is suitable for a hosiery kit, because they are very simple to use in combination with simple dressings that you might have available to you as well. And this is just a case study, which I thought it would be useful to share with you. So this is a patient with a wound on the lower limb. The patient was 90 years old, who has had a mixed etiology pressure, not pressure, also leg ulcer present for more than 10 years. So we know that it was mixed etiology because his ABPI results were not within that 0.8 to 1.3 range, so not suitable for full compression. It's impacting on the patient's quality of life, so he wasn't able to do the things that he wanted to do. So when an assessment was done on this patient, the healing objectives that were identified were that we need to do some really good preparation of the wound bed, the wound edge, and the peri-wound skin. We need to get rid of any non-viable tissue to disrupt any biofilms that might be causing us a problem. And this patient was showing signs and symptoms of infection, so we needed to manage that bacterial burden as well as causing that disruption to those biofilms. We also needed to manage the exudate really effectively, make sure that we protect any granulation tissue and protect the wound edge and the peri-wound skin from the damaging chronic wound fluid. So preparation that was used for this patient was all prep pad. which is a mechanical debridement tool, which is a really simple to use mechanical debridement tool, which is really effective at removing those barriers to healing in terms of devitalized tissue at the wound bed, the wound edge, and the peri-wound skin, and also causing that disruption to the biofilms. And then initially, this patient was treated with an antimicrobial dressing. So in this case, it was Biotane AG non-adhesive, which was able to deliver that AG, so that silver antimicrobial, directly to the wound bed because of its conformability to the wound bed. And this patient, as you can see from the images, wound leg ulcer made significant progress. He was able to tolerate some mild compression, which he hadn't been able to do before because of the pain and the distress that his exudate was causing him. And after managing initially the wound infection symptoms that were identified, he was able to revert to using a non-antimicrobial dressing. So he was able to share in his care by using Biotane silicone, which is a simple to use silicone foam, underneath his compression hosiery, and the wound healed after 54 days of treatment. So I did mention earlier on when we started the session about using a simplified pathway to managing or healing venous leg ulcers. So the pathway is essentially you do your wound assessments using a simplified wound assessment framework. So you do your holistic assessment, you look at the wound bed, then the wound bed, the wound edge, wound bed, the wound edge, and the surrounding skin or peri-wound skin. You identify if the patient has any red flags. Do they have any signs that they might have some arterial insufficiency? If that's yes, then obviously you would address the wound as per your local pathways and guidelines and refer on to the appropriate specialist, again, based on what your local pathways are. If the patient doesn't have any red flags to arterial insufficiency, then you might consider that you have the capacity to do an ABPI or do the investigation into what the arterial supply is quite early on. But you might not have the resource to do that initially. What we want to do is to get that patient into the necessary treatment at the earliest opportunity. So you would, if you've not been able to do the ABPI within a short time frame, you would again look at what your treatment objectives are, refer to your own dressing selection guides, and get that patient into mild graduated compression or 20 millimeters of mercury if there are no red flags present, and then plan and complete that ABPI within 14 days. If you're able to do the ABPI at the earliest opportunity, then that's fantastic. Look at what that ABPI range is. Is it between 0.8 and 1.3? If it is, then get that patient again into strong levels of compression. Again, using the dressings based on what your local pathways and formularies are. If the patient doesn't have an ABPI within that range, then is the wound improving using the mild compression that you've already implemented? If it's not, then you need to review your assessment and then refer on based on what your local pathways are. If the wound is improving, continue your current management using that mild compression, and again refer on. Always making sure that we revisit our assessment to making sure that what we've implemented is achieving the outcomes that we want to. And there are simplified options in terms of your products as well. So again, we refer back to the three-step approach. You've done your assessments, you use a simplified venous leg ulcer pathway. You've implemented really robust wound preparation, because we know that's absolutely fundamental in disrupting those biofilms and getting these wounds on a healing trajectory. And then we need a simple choice into how we manage these wounds in conjunction with our compression therapy. And you can see the simplified dressings that you might have available to you. So in conjunction with compression hosiery or leg wraps, if there's no infection present, we have Biotane silicone or Biotane silicone light, depending on what your exudate levels are. If there is signs of infection, then Biotane silicone AG, which has got that active sustained release antimicrobial to make sure that we're combating those signs of infection, we're reducing that bacterial proliferation. Or we potentially have patients who have leg ulcers with increased levels of pain. biotin ibu might be an option for you, which delivers localized topical anti-inflammatory to that patient's wound to reduce the amount of pain. In conjunction with compression bandaging, then we have silicone non-border or biotin non-adhesive, which again will, as with the other dressings, conform to that wound bed to make sure that we fill out all those little nooks and crannies and fill that gap to stop that exudate proliferating and stop those bacteria from proliferating. We might want to use, if there's signs of infection under compression bandaging, biotin AG non-adhesive. And again, we always have biotin ibu available to us as well. So really simple dressings to use, which are going to achieve the results that you want them to. So we've looked at all three steps. Step one being the assessment using a simplified assessment framework. We've looked at wound preparation, and we have simple tools available to us to make sure we do the really robust wound preparation to remove those barriers to healing. And we also will get the best out of the treatment that we use if we do really good wound preparation in step 3. So we need to have access to simplified dressings to use under our compression therapy to help manage those venous leg ulcers. We have some more Making Life Easier webinars, which I'm really pleased to share the dates of those with you today. So you can have access to these if you visit our Coloplast professional website, but also there's a QR code on the screen here, which you can sign up for. So in January, we have a Making Life Easier in how we simplify wound infection management or healing. We have a national virtual coroner's court, which focuses on a patient with a leg ulcer. And we also have another a repeat episode of our wound infection webinar on the 17th of January. February, we are going to look in a bit more in depth at how we simplify the healing of skin tears. So we have 2 sessions for that. And in March, we look at pressure ulcers in a bit more detail as well, in how we simplify the healing of pressure ulcers. So that's all from me. What I'll do now is I'll stop sharing my screen and I'll ask Charlie and Sam maybe if there's been any questions in the chat or any comments that people have made about the session today.
Hi, Ellen. That was a brilliant session. Thank you so much for that. The chat's been quite quiet. There was a little bit of chatter around non-compliance with patients, and Sam and I advised that it's really important to communicate and educate your patients around their treatment and get them involved with their treatment, because that can help with that non-compliance. But it's also really important to continue having those conversations, as you said, and I think Sam said as well in the chat, and make sure that they're being documented, the conversations that are being had between yourself as a healthcare professional and the patient, to ensure that it is documented that you are having those conversations.
Yeah, absolutely. And I think you're absolutely right. It's involving, it's having a communication with the patient in what it is that you're doing and why you're doing it, and involving them in the choice, because that is absolutely going to help with concordance if they're involved in the decision making about the kinds of compression that they have. If they are empowered to be involved in that decision making, and also empowered and motivated to be taking part a bit in that care as well. So then they've a vested interest in getting this wound to heal as quickly as possible. So why would we not involve them? Why would we not educate them? Why would we not motivate them and saying, listen, this is your wound, and we are here to help you to get this wound to where it needs to be. We'll work together to achieve this. Absolutely. And like you say, document everything that you do, and all the discussions that you have.
Brilliant, thank you. There is just a question that's come in around that, so sort of step 2 in preparation, and around the use of larvae and maggots, and if that could be further explained, please.
Yeah, so maggot therapy is an effective way to prepare wounds. So maggot therapy are essentially sterile maggots that you can get. They're available on prescription that you can get to use and apply to wounds to help remove that devitalized tissue. So the way the maggots work is that they produce secretions. So they will essentially eat away, if you like, or ingest any non-viable tissue on the wound bed, and they will remove all of that non-viable tissue, and they will do really effectively in just a few days what some other dressings will take a long time to do. So like your autolytic debridement dressings, so like your hydrocolloids, or your your alginates, or your gelin fibers, which work on the principle of moist wound healing. Larval therapy will do that very, very quickly. So they're often perceived as being quite expensive, but actually they're actually a very cost-effective way to do that wound preparation, because they will do in a very short period of time what the other dressings will take a long time to do. Sometimes, I mean, the biggest barrier to using larval therapy is the yuck factor, in my experience. The patients feel a bit squeamish about them. Sometimes it's the clinician that feels a bit squeamish about them. One of the things I would say about using maggot therapy is you need to pick your patient carefully. So patients that are on anticoagulants, they need to be under sort of like nursing supervision, if you like, when they've got that larval therapy in place, because of the risk of bleeding. And if the maggots are going to be, I know we're talking about leg ulcers today, but if the maggots are going to be used on a pressure area, for example, if that area is still under any pressure, then the maggots can be squished, if you like. And then obviously not going to get the achieved result. So you need to pick your patient carefully, but absolutely maggots are an option.
Okay, there's lots of thank yous for a great session. A few people asking about the slides and certificates. So certificates and a copy of the leg ulcer pathway will be emailed out to everybody.
Yes.
We won't be sending out the slides, but there will be the recording of this session will be available to you to rewatch if you want to watch over it again or share it with any of your colleagues.
Fantastic. Well, thank you, everybody. Thanks, Charlie. Thank you, and Sam. And thank you, everybody, for joining the session this evening. We all at Coloplast hope you have a happy and peaceful Christmas, and we look forward to seeing you in the new year at our next webinar session. So thanks, everybody.
Merry Christmas.